Welcome to iConnect, a podcast from Ocular Melanoma UK, where real people share real stories about life with and beyond this and other rare cancers. Ocular Melanoma UK knows just how powerful it can be to hear from others who truly understand the journey. From laughter to loss, science to support, each episode connects voices from across the ocular melanoma community. iConnect, bringing together people and stories. Today on iConnect, we're talking to Dr. Carol Davis, who has spent more than 3 decades working in palliative care across hospitals, hospices, and community services. She trained in oncology at St Bartholomew's Hospital and later became a senior lecturer in palliative medicine at the Royal Marsden, before helping establish the hospital palliative care team at University Hospital Southampton in the mid-1990s. Throughout her career, she has been recognised for her work in proving how palliative care is integrated into hospital medicine, particularly supporting patients earlier in their illness, alongside treatment, rather than only at the very end of life. Today, we learn what the term palliative really means. Carol, thank you so much for joining me today. It's a beautiful day as well.
It's a pleasure.
So I know you've been up to all sorts today, but in your real world life, that word palliative, and it's really scary. People get told, well, we're going to introduce the palliative team or the palliative care or send you to hospice or we'll bring in a palliative consultant. What does it actually mean in practice?
Okay, so the word palos, which is where the derivation of palliative comes from, to cloak. So the traditional meaning of palliative care is to cloak symptoms, so I to treat symptoms. And very much back in the early 90s, it was about care of people who were going to die very soon. So I spent my career, in fact, even before I specialised in palliative medicine, which was in 1992, so a little while ago, even before that, I spent time explaining to people what it was and debunking some of the myths and reassuring people. So I think in practice, what modern palliative care is about helping people live as well as they possibly can. And that's it. That is it. Well, with a caveat, in the face of a serious illness. So we don't help somebody with asthma or not that asthma isn't a problem to people, but it's bigger illnesses than that. You know, it's changed so much, Joe. When I first qualified as a doctor, and I won't tell you what year that was in. When I first qualified as a doctor, if we wanted to refer somebody to a hospice, I had to fill in a form to say that I thought they'd got less than 6 weeks to live. Now, hospices have got gyms, not for the staff, but for their clients, for the ill people, to do rehab, and they're just different places. And so, very, very much, modern palliative care is about helping people live well, which of course means as good a quality of life as they can have. And modern palliative care also isn't just about people with a progressive disease. There's a whole branch of palliative care which, because people were scared of the word palliative, like you said, is now called supportive care, but it is really a branch of palliative care where we would be involved in the care of people who might even have a completely curable cancer, but have got symptoms either from the cancer whilst they're having treatment or from the treatment itself. And we can help people be well enough to have treatment. And that really opens people's eyes up. They realise how broad palliative care can be. It does vary in different parts of the country, and some services are more progressive than others. And I led quite a progressive service, but there are many other progressive services as well.
Meaning what? Sorry, Carol, meaning what? When you say progressive?
By progressive, I mean pushing the boundaries. So for instance, from early on in Southampton, where I worked most recently, we were absolutely seeing as many people as we possibly could who'd got diseases other than cancer, as well as people who'd got cancer. Because traditionally, palliative care was not only for people approaching the end of life, or probably approaching the end of life, because it's sometimes a bit more uncertain than people realise, but also for people with cancer. So we and others around the place were pushing it for people with non-cancer. So I've done lots of work alongside young people with cystic fibrosis, young people with congenital heart disease. And in the last decade or so of my career, I retired just very recently. I was one of the pioneers of bringing palliative care into the intensive care unit, where everybody's facing uncertainty, where the symptom burden is very high, and where far more ill people are awake than people who have not been to an ITU realise. So it's
Okay.
much broader. I hope that addresses your question.
Yeah, absolutely. I hope it gives a lot of people an answer and alleviates some fears around it as well. And you use the term palliative medicine. So, as a doctor, as a consultant, would you prescribe medicine? And that's part of the care I'm asking?
Yes, that is one bit of the care. I worked predominantly, although not always, in acute hospitals, large acute hospitals, the Royal Marsden Hospital first and then Southampton General. And I actually chose not to prescribe, not because I couldn't prescribe, but because I wanted the people whose name was at the end of the bed, the team who were actually ill person was under their care, to know what the patient was on and to agree that they were happy with those drugs. And also, theoretically, at least, they ought to know that person better than we did. Many people I saw longitudinally, some on and off. You can dip in and out of palliative care. So some on and off over years. And then some of the young people with cystic fibrosis went on to have lung transplants. So we didn't need to see them anymore. And that was
Okay.
great. That was great.
Yes, I can imagine there's some incredibly rewarding aspects to your job, but also I would imagine the emotional burden that you carry of people who may be in your care for quite a lengthy duration of time. What's actually harder if you come into an ITU situation and you meet someone who's, God forbid, been in a car accident or something's happened to them, and you're given something like that, or someone that you form a relationship with?
Oh, that's a really
How do you manage that emotionally?
That's a really good question. Well, so first of all, a lot of palliative care is about focus. And sometimes you can meet somebody once and both they and you can walk away feeling you've been involved for quite a long while. Now, I don't mean a long while on that consultation, but it's about the depth of the consultation, and it's about listening, and it's about following to a large degree the ill person and their family's agendas, but also pushing where you need to. So the answer is they were both sad. I talked earlier about spending my career reassuring people, which I have done on doorsteps when I used to do home visits. You know, you'd arrive and people, or in intensive care or in the cancer clinics or wherever I was going, and the young people with cystic fibrosis, it wasn't usually them we needed to reassure, it was their parents. But that's a whole nother thing. You just, it's about humanness. A lot of palliative, I'm not saying other doctors and nurses aren't human, of course they are, but there's something basic about palliative care, which is about being alongside human beings, and in the main, human beings facing uncertainty. And so, really weirdly, sometimes when someone has a definite diagnosis or a definite prognosis, not that prognosis can ever be absolutely accurate, but I'm really sorry, your disease is escaping the control of the radiotherapy or the surgery or the immunotherapy or whatever it is, you know, this is going to get worse. You have to help them reset and reframe, more living for the moment rather than fearing the future, if that makes sense.
Absolutely. I mean, it kind of it means that when you walk into a room, you're not the Grim Reaper. You're actually coming in to hold somebody's hand and help them carry the end of their journey
Yes,
until
I've
they get
always
kind of
I was
until
no,
they get to the end of their journey.
yeah, I was known around the hospital for always wearing bright clothes, and I like colour anyway. But I think that a little bit of that was about not being the Grim Reaper, dressed from head to toe in black. Having said that, looking after people who are actively dying is and always will be part of palliative care, and it's a really, really important part of palliative care. And there's only one chance to try and help get things as right as they can be for somebody, and their family. And so that's very, very special too. But I think they can both be very difficult. I can think of, without going into too much detail, some of the cases that I'll never forget. Some of the situations, a young girl whose cancer was diagnosed when she was pregnant, went in to die when her baby was just a few months old, with her baby lying on her tummy, and a few stories like that, which were very, very sad. But also, there's as many really good stories. And we don't try and be godlike or magicians. We just try and make things as good as we can. And it's a very rewarding thing, because for us, and hopefully for the person receiving it, because we need to think laterally. So we might come up with some really unusual ideas that might help, but we personalize it. So it's all about the person, and they can say to us, "No, I don't fancy that." So, for instance, I used to do lots and lots of work around people who were very breathless for whatever reason. And I used to give them a menu. I used to talk about it being like a pizza menu. Okay, if you're looking at a takeaway pizza menu, there's all these different options. There's some you know you like, there's some you know you don't like, and there's some that you might give a try. Here's 5 things. Think of it like a pizza menu, and you tell me which of these ways that might help your breathing you want to try. So a lot of it's about, that's just an example of restoring control as well, because that's what a lot of people
Yes,
feel they've
I've
got.
spoken a lot about restoring yeah, yes, exactly. And I spoke with previous guests about actually restoring control, and that was around putting LPAs in place and
Yeah,
writing wills. And actually, although that seems a little bit doom and gloom, it gives you the control that you know what's going to happen to your dog, and
yeah,
things
yeah, yeah,
like that, because the
totally.
stuff has to be discussed and things have to be put in place.
Sure. Some of the most frightened people I've met have been more worried about their cat and their dog than anything else.
Yeah,
there are
I can
ways
I can
to
well
it.
believe
And
that.
putting your house in order is no bad thing. In fact, it constantly amazes me how few of the population have actually made a will. I mean, everybody should have a will, but there's lots of people who haven't, for instance, let alone
No,
LPA and
and
things like that.
that was something we spoke about. Yeah,
Yeah.
no, very much so. I'm firm believer in that. But you work very closely with the medical team, do you?
Yes.
Or do
Yes.
they allow you to have free rein on your patients?
That's a very good question. Quite an unusual question, but a very insightful question. On the whole, yes, but you have to sort of prove your worth a bit. And I think, and I've got many friends who are surgeons. But I think surgeons, and some surgeons, are a slightly different breed of doctor than palliative care. And so if you're a surgeon, you're always trying to make somebody better by removing something. And there's a little bit of a issue occasionally between a surgical team wanting to refer to the palliative care team. On the whole, general practitioners, community nurses, respiratory teams, uh, oncology teams, very, very, very close working relationships with palliative care. I'd say the one that can be occasionally a bit ambivalent is surgery, but nonetheless, I've worked alongside many, many surgeons very, very constructively and happily.
Okay. They're often known as the carpenters in the profession.
And there's
Having
many.
undergone a lot of orthopedic surgery myself, you say they're up for taking stuff out. They also put things in.
They do put things into, but they fix it, don't they? They fix it, whether it's taking something out or mending it. Yeah, they're known as
Yeah,
many things, but yeah, I'm not going to go into that this afternoon.
I think we'll stick with carpenters. I think that's quite a bold statement. The intervention of early palliative care. I mean, you said that in times gone by, actually not that long ago in the 80s and 90s, if you had what they considered 6 weeks to live, that's it, off you go into the hospice, palliative care, yada, yada. So have you found, as things have changed, that the intervention of early palliative care has given the patient and their families a much greater opportunity to see the future, however the future may look? I mean, it may have been a short looking future, but the intervention of palliative care being brought into their world, um, the reassurance surrounding it. Like you said, you come in and the word, it's a cloak. I think of the word cloak as almost like big fairy wings giving you a hug.
Yeah. Yeah, maybe. The answer is I couldn't have phrased it better myself. I mean, that's exactly what it does do. There's also really good scientific evidence now, a lot of it from the cancer world, none around ocular melanoma that I'm aware of, perhaps because it's a rare cancer, which maybe we'll talk about a bit later. But big studies from America around lung cancer, and so they did randomized trials, and one group had standard North American treatment of their certain type of lung cancer, same lung cancer, same type of lung cancer. The other group had that alongside regular active palliative care input from diagnosis. Guess what? The second group, the ones who had the palliative care as well, had better symptom control, more mobility, and lived longer. Perhaps because of those two things.
Which at
But
the
I'm
end
not
of the day is actually what we all want.
I'm not saying that's always the
Yeah.
case. And palliative care it affirms life, and it neither hastens death nor necessarily postpones it. But actually, that study strongly suggests that it does sometimes postpone, probably by people feeling more empowered from the psychological aspects of all the support they get alongside other supports, and also having their symptoms better controlled. And there's other studies too, there's a growing body of evidence about it.
That's really interesting. And the fact I'm so pleased that these things are actually being studied now. I mean, so often you'll talk to medical specialists. I mean, we were in the company of a neurological surgeon yesterday, for my father, and myself and my mum raised some concerns around, not concerns actually, observations around my dad's symptoms. And again, we're dealing with a surgeon who was very, well, that hasn't been reported and that hasn't been this. But if palliative team were involved, then it would be the palliative team who would say, okay, well, let's try and manage that symptom, or let's see what we can do with that, which again would bring in that cloak and that
Yes.
comfort
Yeah.
and
I mean,
care
as
and
well,
support around it.
in a situation like that, we'd also be asking the why. So we'd be asking, because actually knowing what's causing a symptom can help you address it better. So we would be asking the why.
Mhm.
Why has the person got this particular symptom, and trying to work that out. So we would be talking to the neurosurgeon about whether, say, any other. I'm not particularly talking about your father now, but whether any other imaging or
Oh, no, no, no,
investigation
no, not at all.
or anything like
Yeah.
that, because that will help us to come up with other ideas about helping the symptoms. But yes, that's exactly what we do.
And quite often stuff gets kind of, you hear the words, well, that's not been reported on, or that's quite rare. You mentioned the words ocular melanoma. I mean, you were based down in Southampton, so you will have come across patients with ocular melanoma. How did that enter into your world? So let me rephrase that. Something so rare, actually, is the care any different? Did you find that you had to go and study? Did you have to do further educational things around understanding the symptoms and how treatment is managed? I mean, treatment is still totally out there at the moment, and we're all living on a precipice, hoping that there's a clinical trial that's going to come in and actually just wipe out ocular melanoma, which would be fabulous. But how does something like a rare cancer or a very rare condition look in the eyes of a palliative consultant?
That's a very interesting question. And I guess if it's something you haven't come across before, then the first thing we do is talk to the team looking after that person. And also, yes, read up about it, ask questions, and learn from the person who's going through it. Because most people are pretty informed about what's going on and in tune with their body. Not everybody, but most people. So, I think it was Hippocrates, the father of modern medicine, who said, listen to your patient. He is your textbook. I'd add it, he or she is your textbook. You'd learn from all those different things. You might go back and you might do a search on symptom control if it was a particularly unusual symptom cluster. Symptoms often come in clusters, in little groups. So especially if it was an unusual symptom cluster, you might just go and have a sort of guided think through either a person who specializes in it or a charity such as Ocular Melanoma. Nothing to stop us contacting the charities as well. But that's what you do. But I think the other thing about rare cancers is, um, so it presents some challenges for us, but rather a challenge than to try and lump all people with any cancer altogether, because they're different. Different cancers behave differently, and rare cancers bring their own issues. So things I remember from people, not that many, but a few people with ocular melanoma whose care I was involved with, was things like a sense of isolation, particularly around diagnosis. It's a rare cancer. When I try and explain it to my family and friends, they don't know what they're talking about. Melanoma? In the eye? No, 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 no. It's in the skin. Are you sure it's not something else? There must be people listening to this podcast who've come across that sort of thing. So I think that's
All of us, most of us.
well, indeed. And then everyone with any serious illness lives with uncertainty. But if you've got a rare cancer, I suspect that it brings even more uncertainty. You mentioned about different treatments just now, but also there'll be healthcare professionals who have never ever come across it before. Your GP may have never looked after anybody else with ocular melanoma. So it brings its own issues as well, doesn't it? And so whilst this will be specifics related to the fact it's melanoma and the site in the body where it is, the eye, there's also issues about how healthcare professionals, how much healthcare professionals know or are willing to learn about it to help be alongside you. Um, and I think we need to put the person
Yeah.
who's in the driving seat, telling us what it feels like and what
And
the
quite
issues are.
often, as you say, that can actually be the patient.
Yeah, absolutely. That's what I mean. They should be in the driving seat.
Yeah. Well, to anyone listening, you are your own advocate. You probably know your body better than anybody else. And if people, I've discovered quite often, you go somewhere, you go to an appointment, even at your local optician, and they do the OCT scan, and someone will say, "That's the woman with ocular melanoma." And all of a sudden, all the opticians are in the room because they've never seen one. And I think it's been a fascinating experience over the 8 years, 8.5 years. I'm now into this journey myself, to educate the medical profession and those around me in what it looks like. Have you ever seen one? No, I haven't. Well,
Yep.
mine's actually very difficult to see, but if you make sure that you get all your people to look extreme left and extreme right and up and down, and you talk about the importance of
Yep.
eye dilation and this, that, and the other. I have only come across people interested to learn. And what is fabulous through Ocular Melanoma UK, that we have the psychological support, and the people who take our psychological support actually understand the condition. So you don't end up kind of educating in your appointments, which you can come out and think, I'm exhausted.
You don't need that on top of everything else. You've got enough going on already. But
No, absolutely. Yeah, absolutely not. I mean, the future, obviously, it feels overwhelming. And navigating these conversations around end of life, is that something that's done generally within a hospital, or do people always move to hospice? And you said there's people with other conditions now in hospice care. Were you stationed in the hospital itself?
yes. So I chose to specialise in hospital palliative care, partly because it wasn't very well established back in the early 90s when I was carving out the first steps of my career and where I wanted to work. I have worked in a hospice and indeed run a hospice for a while. And I've worked in the community, but my true love was always the acute hospital. I think it just suits me. I'm a big fan of lifelong learning, and you can lifelong learn in any career, and certainly in medicine you can, and you could in any branch of palliative care. But there's something about the acute hospital that used to throw up the weird and the wonderful things as well. And there were always people, if I wanted to learn, I could go down to the X-ray department and get the X-ray doctors to talk me through a scan that I couldn't interpret myself, or I could contact the ophthalmologist to give me a quick few minutes on ocular melanoma, or more than a few minutes, or whatever it was. So I specialised in acute hospital medicine. That was my milieu. That was my place I wanted to be.
Okay. And how long were you there for, Carol?
Well, I became a consultant in palliative medicine in '92, so I was a acute hospital palliative medicine consultant for 33 years. Yeah.
Wow. Okay. Well, thank you. I'm sure there's a lot of families who would like to thank you for the care that you put in. Um, Clinicians, and I'm sure you do as well, or have done, would talk about a good death. I mean, I'm
Yeah.
not being funny. We all
Mm,
know that that's the one thing in life that's certain. It's not a phrase that's used.
it is used. I don't use it. I don't think I've ever used it.
Okay.
I think to talk about a good death makes a value judgment about death and a value judgment about that person, their family, and everything. I think we should talk about when the time comes to be starting to die. It's about any symptoms. You're not necessarily ridden with symptoms. That's not necessarily the case at all. Some people don't need, everyone thinks somebody with advanced cancer needs loads of morphine or whatever. There's loads of people who don't need any because they haven't got any pain or any breathlessness or anything you might use morphine for. So it's about symptom control where necessary. It's about dignity. It's around unfinished business. I've seen so many families reconciled when someone's very, very ill and approaching the very end of their life. And it's about, I suppose it's about as natural an ending when that time comes, and everybody is going to die. I know that I don't mean to sound trite in any way, but everybody's going to die sometime. And it's
Yeah.
about making it as human and as dignified a thing as possible, I think.
And have you found during that time, have you brought in any holistic methods at all? Is there a trend towards a more holistic approach to palliative medicine?
Yeah, I mean, I think, well, I don't think I know that palliative medicine the inception of modern palliative medicine is probably the sort of 80s onwards, and it's always been part of it, as has multidisciplinary working. So there's always been a lot of physiotherapy, occupational therapy, psychology, social work, nursing, doctors, all alongside each other. So and then there's a lot of complementary therapies, a lot of hospices. As I say, they have gyms, but they also have complementary therapies available, different ones in different places. Everything from Reiki, Indian head massage, through relaxing massages, through acupuncture. I've done research on acupuncture for breathlessness, and it works. Anyway, we'll put that to one side. So
You look surprised.
no, I'm not. I'm not surprised. I'm not surprised. I'm not surprised. Actually, I think acupuncture is a very interesting treatment. But there are some people who wouldn't want to go near an acupuncture needle, go anywhere near them. And if they're
I've got one of those here.
yeah, there's no point. There's no point even mentioning it as a possibility. So yes,
No, absolutely. He'd be on the floor if you pulled a needle out and said, "This is going to help." But no.
yeah,
But I mean, many listeners here are living with long-term diagnosis. For someone newly diagnosed who feels kind of frightened about their future, what's your kind of go-to? Well, is there a go-to that you would say to somebody, or how does it start? Do you say to people, "Well, here's a list that I've been given by your medical profession. Now let's sit down and talk about how you quite like this to go."
So, thinking about uncertainty, and first of all, I don't think human beings do uncertainty very well. And people with serious illnesses, including cancer and including ocular melanoma and rare cancers, face a lot of uncertainty. And there's a number of different ways and techniques, and psychologists are great at helping people with anxiety as well. But essentially, I think the key to anxiety is somebody asking themselves the question, or I might not control the uncertainty, but I can choose how I live alongside it. How am I going to do that? And then we can give pointers. Like, find the things that you are in control of. And there are ways of living alongside uncertainty, like short-term goals. It doesn't mean that you've necessarily only got a short term, but it means you've got something to look forward to. So if you're just approaching the end of treatment, have something to look forward to, and don't fret about the holiday in 2 years' time that you were thinking of maybe taking. Think sooner. And then remember Tarzan. Remember Tarzan. So Tarzan never let go of one hanging branch till he caught hold of the next one. So never have one really nice thing you're looking forward to till you've got the next thing booked up in your head or planned in your head. So you've always got something to look forward to, just little tiny things like that. There are far more sophisticated things as well. Or some people will find mindfulness helpful, or other psychological coping strategies. There are lots of different things, but it's actually about how that person learns to live alongside the uncertainty that is to some degree or other inherent in the situation that they're in. I think it's more about a lot of an initial consultation is understanding the person, and if you can establish how in their life they've coped with difficult times before, that's useful to be able to talk about. Whether they've faced uncertainty before, whether they've got any experience of people with cancer, and you get all sorts of stories, often from a long time ago. Um, I remember it's nothing to do with cancer. I remember looking after somebody who had tuberculosis very severely, and they were really, really anxious to a degree that was quite unusual. And by asking the questions and them opening up, it transpired that they remembered their grandmother dying in a TB sanatorium, who was
Okay.
isolated in the countryside, wheeled out onto the balcony every day, and they had felt it had this stigma, and that was a really, really big thing to them. So you can't always guess, and I've never worked to a list. The only list we'd normally work to is the list of what that person says. So, a very good question is, tell me, what's bothering you most at the moment? Or if you had a list of issues that are worrying you at the moment, what would be on it? Or can you give me a few things that you think we might possibly be able to help with, or you want someone to try and help with? And those sorts of things would lead it more than a list from anywhere else, more than an extraneous list.
No, and having spoken to you on the phone before we went ahead and kind of battled it out, as it were, on the podcast, I know and I can hear your just incredibly human approach to it. There must be an element of psychology in
Hmm.
your world. I mean, are you trained in psychotherapy and psychological support yourself, or is it just a part of your personality?
I'm not a psychologist. I have always been interested in psychology. And then I think I mentioned earlier that one of my main interests, regardless of what was causing it, was severe breathlessness and the anxiety that often comes alongside that. And so I took myself off on various cognitive behavioral therapy courses and things like that a long time ago. And it did very much influence my management of how I used to make those personalized plans, the pizza menus of things like visualization or relaxing all your muscles and things like that. So psychologists can be extraordinarily helpful. There aren't enough psychologists to go round, and we might refer to a psychologist if we have a psychologist to refer to. So I don't think any palliative care nurse, doctor, or any other palliative care professional should bite off more than they can chew. And I'm aware from the different people I've worked with over the years, some people are more comfortable with that side of it as the doctor or the nurse than others. And I've no doubt that people receiving such care are aware of who's more comfortable with that sort of thing and who's not. I mean, patients aren't stupid. Ill people choose who they want to say what to, don't they? So you might
Yeah.
choose to say something to somebody, but not to somebody else, and that's fine. And so, you need all sorts of different sorts of different styles.
Tools.
Yes,
Yeah.
tools in the toolbox, styles. approaches, communication skills. And that's, I guess, what we're really talking about from a selfish point of view is why I love my career.
Yeah. No, absolutely.
I loved about it and I loved making a difference. And that's why I'm now doing some voluntary work, which is outside medicine, but I still feel that I'm making a difference. And that's very
What
important.
voluntary work are you doing at the moment?
Uh,
Can you share with us
yes,
what you're doing?
I can broadly. I'm working with a youth charity with some young people who are being schooled outside school through the charity, and I'm
Okay.
supporting them in that, and hence in wider things as well. And it's great. And it kind of builds on some of the skills that I hope I had already, some of the skills that I honed during my career. And it's pushing me to learn new things and be alongside people I wouldn't normally be alongside. And that suits me.
I'm sure with your focus around working with people who've got breath issues, a young person in that kind of setting might have a panic attack. And that's all around the breathlessness. Do you use breath work at all? Have you used breath work in palliative care, and do you
Oh,
use it
massively.
now in your charitable role?
Yes.
Okay.
Yeah. I don't tend to use the breath work where you count because very anxious, panicky people don't tend to not find counting so helpful. And they find some of the other techniques like there's a thing called the calming hand, which is you teach people to look at their hand and think of a word for each one. And when they get round to the last digit of their hand, that's accepting. Accepting I'm short of breath, but I'm going to be okay. But again, if someone's really panicky, they can't remember that. So you need simple things. And so the sorts of things that I found very successful were explained to people that when you're panicky, your fight or flight hormone, adrenaline, is being activated. And that's why your palms are sweaty, your heart's racing, and you're feeling all het up. And it's also why your shoulders tend to hunch up. And the worst position for someone who's short of breath is like this. I've seen thousands of people who are breathless like this. And the first thing you do is say, "Can I touch you?" And they go, "Mm." Say, "Just drop your shoulders. Start with your face. Relax your nose, your face, your jaw, your shoulders. Stretch your arms out. Flop and drop. Let your muscles breathe with you, not against you." And that helps nearly everybody. And then there's a whole pile of other stuff you can do.
You've got this armory of things that you can bring in.
Yeah.
Is there anything really
It
random?
I've used it in the gym. There's a lady I know in the gym who's got some post-COVID lung problems, and
Okay.
she was talking to me and about her breathing, and I taught her some of that, and she said it made a massive difference to her. So it just goes to show that you can
Fabulous.
use these techniques in all sorts of situations to help all sorts of people.
Well, I mean, there's been an incredible number of people who will have benefited from your love, your care, and your experience over your time. Does anything come to mind that's made you laugh, or is there anything really odd that you've been asked to do? Have you got any funny stories at all?
Yeah, I've got quite a few funny stories. I'll tell you one about
Anything you
breathlessness.
can share?
So the other thing I did a lot with around and still do around anybody who's breathless or panicky is see if they can visualize something, a happy place, a nice place, a go-to place. It's quite often a beach. It doesn't need to be a beach. Anyway, I've got a couple of funny, well, I think they're funny. I hope you do as well. Stories about that. One was a lady, again, she didn't have cancer. She had COVID and had been on the intensive care unit for months and months and months, very, very ill. And she was newly off the intensive care unit. And that transition point of intensive care to a ward in a hospital is a really big one, and one that people tend to struggle with a lot. I mean, after all, you go from one-to-one nursing to being on a busy ward, let alone everything else that changes.
Yeah.
And anyway, I was asked to see this lady about her breathing, and she had a panic attack whilst I was there, which she later assured me was not because of me, but because she was getting them very, very regularly during the day. And so I'd hardly got to know her. And I said, "Have you got a favourite beach?" And she looked at me like I was bonkers and said, "Yes." I can't remember. Let's say Bognor Regis. I can't remember where it was. And she said, "Yes." And I said, "Okay, right." I did the relaxing the muscles things. And then I said, "Just drop, Just imagine you're on the beach. It's all calm. The waves are coming in and going out, just like you're breathing in and slowly out. Slow your breathing down, out, slow it down. Oh, she went into this sort of trance-like state, so much so that I was actually really quite worried. And in the end, I had to give her a shake and say, just checking, are you all right? And she broke with a start and she said, oh, oh, I thought I was on the beach. I could even feel the tide on my feet. I knew that lady for years. She had other problems as well as her COVID. And I was involved in her care on and off, because as I said, you can dip in and out of palliative care on and off for years. And she used that strategy, and she did die of some medical problems, but she used that strategy until and as she was dying. And another story, which perhaps is funnier, was a man who was very, very short of breath. He had a cancer in his lung, and on top of it, he'd got some clots on his lung on both sides. So that's a lot of things gone wrong in his lungs all at the same time. And he was very, very ill and very, very short of breath. And his son was sat by his side when I approached the bedside to say hello for the first time. With that what we talked about earlier, palliative care turning up. And they both looked anxious. They both had their shoulders in the sky, to be honest. Anyway, I did some stuff with him, and we did this beach business. And this beatific smile came onto his face, and his breathing calmed down. And then he opened his eyes, and it had all settled, this major panic that he'd been in. And his son said, gosh, Dad, you look so much better. And he said, oh, I feel better. And the son said, Dad, what beach were you on? And he smiled. And then the son said, and who were you with? And the really ill, dying man said, and we all laughed and laughed and laughed. It was really funny.
Oh, that's lovely. I was expecting you to say a nudist beach somewhere.
Oh, no. No.
No, that's really sweet, though.
Yeah. Mind you, that might induce panic in some.
Well, yes, quite often. Carol, thank you so much for sharing some of your experiences, your passion, your life journey as the best support network that a family and a patient could wish for. And there must be so many people out there so grateful. And I hope they get to see you in our podcast. And yes, a big thank you from everybody.
That's very kind. There are lots of people like me out there, and in palliative care and in other branches of healthcare and in other branches of life. But thank you very much for that. I've enjoyed talking to you. Thank you, Jo.
Thank you, Carol. If you or someone you know has been affected by the topics discussed in this episode, support and information are available. You can visit Ocular Melanoma UK at www.omuk.org for guidance, resources, to connect with our helpline and others who understand. Remember, no one should face ocular melanoma alone.